This is your introduction to the Integrated Management of Childhood Illnesses chart books. You'll first meet the 2014 generic World Health Organization chart book for 2 to 60 months, and then you will be introduced to the 2019 section for the birth to 2 months. The WHO put out a generic version for the newborn age group, which is where most of the mortality is in the first month. That is a very critical time, and it's important to periodically update with new findings, new guidelines. In the last number of years, there's been more and more good information about HIV in the booklets. So we expect this to be a work in progress, always being updated, always changing, and every year people who are interested in the practitioner side of medical brigades should check for new updates for the region they're working in and also on the WHO webpage. So this is the cover of the March 2014 chart booklet. This is the index. You will see that this gives you the information about assessing and classifying the sick child, treating the child, follow-up recommendations, counseling for the mother, a lot of information about HIV, the routine things that we always talk about, vitamin A, amebendazole, or more often we'll use albendazole. Some treatments that they're recommending just to be given in a clinic. The specific chart books for specific problems are introduced. Ready-to-use therapeutic food on page 21, very important section. And HIV, even if people aren't specifically initiating or treating HIV, this is a good reference for side effects of the medicines, the usual preferred and alternative regimens. A lot of good information that's good to have even if you are not the person who's actually taking care of the sick child. So let's get started. We always start with assessing for general danger signs. You're going to assess, you're going to decide if the child is in danger, and then whatever other problems they have, you will be treating them with much more urgency if they have general danger signs. So we always work from left to right, assess, classify, and identify treatment. General danger signs. Is a child able to, you ask, then you look. So it's subjective, objective assessment plan. Very familiar, the SOAP idea. You ask, is a child able to eat or drink or breastfeed? Does a child vomit everything? Has a child had convulsions? You look to see if the child is lethargic, unconscious, or convulsing at the present time. If any of those things are positive, the child has very severe disease. You treat them urgently and get them to the highest level of care as soon as possible. The things to keep in mind, treat the convulsing immediately, quickly complete your diagnostic assessment, give any treatment that they need pre-referral, treat to prevent low blood sugar, keep the child warm, and refer urgently. Whenever we say refer urgently, be prepared in resource-poor settings for people not to be able to follow your instructions, even if it is a life-threatening emergency. So be prepared to tell them the most urgent things that you want them to do, but if you don't believe that they're going to be able to do that, do your very best to give them all the treatments they need that you have access to at that. Now, the biggest cause of death of children in the developing world is pneumonia. So we spend a lot of time thinking about assessing pneumonia for pneumonia. Now, as you look at the chart on the right, notice at the top of the chart is always red. That's the severe problem. Yellow is important but not critically urgent, and green is normal or a mild, not a life-threatening disease. So we start asking about the main symptoms. Does the child have a cough or difficulty breathing? If yes, for how long? And then you look, listen, and feel. You count the breaths in 1 minute. And of course, the child has to be calm. If you're scaring them by paying attention to them and you're a stranger, wait till back off a little bit. Watch the child while they're in their mother's arms. And if they're they're breathing rapidly, and rapid is if the child is 2 to 12 months, 50 breaths a minute or more, 12 to 5 years, 12 months to 5 years, 40 breaths a minute per more or more. You look for chest indrawing, you look and listen for stridor, the kind of noise. You listen for wheezing, the musical noises, and if either wheezing, fast breathing, or chest indrawing, you have to think this child may be having an asthma attack, or maybe they have pneumonia. Of course, you keep asking them questions, but in the meanwhile, while you're waiting to make your final assessment, you treat an asthma attack. So you give them a treatment with albuterol, salbutamol, and you can see if their situation dramatically changes. It may have just been an asthma attack and not a pneumonia. Now, it's very nice if you have a handheld inhaler or if you have a nebulizer, but if you don't, you can give them a breathing treatment with a bicycle pump. We have a little video about that, which we'll post with the rest of the material. But if they don't respond to the asthma treatment, then you're more worried about a pneumonia. So if they have any danger sign, you think that they're pneumonia with danger, you give them their appropriate antibiotic and you refer urgently to the hospital, remembering that if you can't get them to the hospital, be prepared to treat them by all means with everything you have while they stay in the community. If they have pneumonia but they don't have any other danger signs, give oral amoxicillin for 5 days. And if they're wheezing or it disappeared after rapidly acting bronchodilator, give them inhaled bronchodilator for 5 days. And if they have HIV, they're exposed or infected, and they seem to be having respiratory distress, chest indrawing, give them, start them on the antibiotic and refer them. Soothe the throat and relieve the cough with a safe remedy. Now, people are always looking for cough syrups, purchasing cough syrups, but there really isn't any child survival advantage with a cough syrup. If there's a local remedy that people use, encourage that. Now, if you're in a place where TB is a public health problem, and then they've been coughing for more than 14 days or they have recurrent wheezing, you want to refer them for TB or asthma assessment and follow up this child within 3 days. If they don't seem to be very sick, if they're in the green, they probably have a cold. They might want an antibiotic like everybody does, but they probably don't need it. And if they seem to respond to the bronchodilator treatment, give them inhaled bronchodilator for 5 days. Soothe the throat, use symptomatic therapy. But if things persist, of course, check them out for TB or asthma. and follow up in 5 days if they're not getting better. And there's some extra pieces of advice down at the bottom. Now remember, you're not expected to learn and memorize from one talk through of the chart books. You can have your own copy, and also this is basically to give you the idea of what these chart books are like, what they're about. Next is diarrhea. Diarrhea is also a huge cause of death in infants and young children. Do they have diarrhea? If yes, for how long? Is there blood in the stool? Look and feel. Look at the child's general condition. Is the child lethargic or unconscious, restless or irritable? Look for sunken eyes. Look for if the child offer the child fluid. Are they able to drink, or are they not able to drink? Are they drinking poorly? Or are they thirsty and drinking eagerly? Pinch the skin of the abdomen. Does it go back slowly? Or you're looking for evidence of dehydration on physical exam. Now, if they have any of the signs of danger, lethargy, sinking eyes, not able to drink or drinking poorly, tenting of the skin, then they have severe dehydration. If they have two of those, severe dehydration, and if they have no other problems but besides dehydration, give the fluid, or if the child has another severe classification with dehydration, then send them urgently to the hospital with their mother, giving frequent sips of oral rehydration solution on the way. Advise the mother to continue breastfeeding. If the child is under 2 or older, and there is a cholera in your area, give an antibiotic for cholera. Now, moving down, if they're just restless, irritable, sunken eyes, but they're eager to drink, if they're dehydrated, give fluid, zinc supplements. Zinc supplements are life-saving with diarrhea. But if they also have something else going on, any other serious illness, send them to the hospital. Advise the mother when to return. If they don't seem to have severe dehydration, they don't have enough signs to classify them as some or severe dehydration, give them zinc, fluids, and keep feeding them. People make a mistake when they stop feeding children because they have diarrhea. That the diarrhea will continue if they are not eating enough to get their bowel to absorb fluid. The bowel both secretes and absorbs, and it takes more energy to absorb than to secrete. So if a child is malnourished, they may just continue with diarrhea that could be stopped if they would be start to be refed. So do not withhold food from children with diarrhea, but of course don't withhold fluids. If they have diarrhea for 14 days or more and they're dehydrated, treat the dehydration before the referral unless the child has another severe classification, and refer to the hospital. If they're not dehydrated but they have just a persistent diarrhea, give them multivitamins and minerals, including zinc, and follow up in 5 days. If they have blood in their stool, they have dysentery, give them Cipro for 3 days and follow up. Now, this is a very busy chart page, but it's a very important one. This is the page about fever. Now, there's a lot of decision points in this. This is complicated. If you're in a malaria region, yes or no? That's an important question to ask. If you can do a malaria test, you're in a malaria region and you can do a malaria test, that's good. If the child has recently had measles, now or within the last 3 months, that is a very serious risk factor for some of the very serious diseases that are prevalent in the developing world. We're talking about nutritional blindness and Noma. So we'll start at the top of the chart, and I must say that we did add some extra chart pages for more decision points with Noma and nutritional blindness, because the references that they're making here on this page to if the child has any change in their cornea or pus draining from the eye, mouth ulcers, those are risk factors. They're referring to the danger of that child going on to have nutritional blindness or Noma. And there's also later on in the chart book more reference to that. So we've expanded on that because it is so important not to be too casual in the setting where those are important public health problems. So if the child has malaria, you're in a malaria area, you ask about the fever, how long, if it's been more than 7 days, has it been present every day, has the child had measles within the last 3 months. If you can do a malaria test, great. And if they've had measles, of course, we pay extra attention to Noma and nutritional blindness. Then look for meningitis. Do they have a stiff neck? Do they just have a runny nose? Look for physical signs of bacterial cause of fever. Look for measles. You know, since 1957, doctors in the developed world haven't had much measles to look at because of the measles vaccine. So we wouldn't necessarily even recognize a case of measles. Look inside the mouth for the white Koplik spots in the mucosa, and also look for the pervasive rash, and also for mucosal changes in the eyes, nose, mouth. Measles is a very epithelial mucosal disease. So if you're in a high risk, high or low malaria risk, you look for any signs of meningitis, treat that child urgently. If they're malaria positive but they're not very sick, then just you can give them treatment as an outpatient. If they're malaria negative and they have basically probably a viral infection, treat them with antibiotic if you find anything, but acetaminophen, fluids, etc. If they have no malaria risk and no travel to malaria region, but they have any danger sign or a stiff neck, refer them urgently, start treatment, refer them urgently. And if they have no general danger signs, no stiff neck, treat their symptoms. If they have had measles and they have any danger sign or clouding of the cornea or deep or extensive mouth ulcers, that's very severe, complicated measles, give the vitamin A treatment, start them on an antibiotic, and refer them urgently to the hospital. Now, the vitamin A treatment, we will expand on that to say give them 1 dose today, 1 dose tomorrow, and 1 dose in a week, whatever is the right dose for their age. If they have pus draining from the eye or mouth ulcers, in the setting of risk of vitamin A blindness and Noma, it is better to err on the side of giving them the high-dose vitamin A treatment, the oral antibiotic quickly. I would have to say I respectfully disagree with the idea of just using eye ointment or mouth ulcers treating with gentian violet, which is just an antiseptic. If you're in a high-risk area, any mouth ulcers in a child who's just had measles, in a malnourished child, that is such a high risk for Noma that I would say it would be better to just put them right on high-dose antibiotics. And the danger of nutritional blindness, give them the triple dose vitamin A rather than just a low dose. If they have measles now or within the last 3 months, but they have no danger signs, still give them the vitamin A treatment. An ear problem. You ask, do they have ear pain? Is there drainage? If yes, for how long? Look and see if there's pus draining from the ear, and feel for tender swelling behind the ears. Mastoiditis is what you're looking for with the tender swelling behind the ear. We don't see much mastoiditis in the developed world, but it's still around, and for children who haven't been had the benefit of antibiotic treatment and are prone to severe infection because they're malnourished, they're at risk for mastoiditis. Start an antibiotic and refer them to the hospital right away. Now, if you see pus draining from the ear and or ear discharge, they have acute or chronic ear infection, treat them appropriately. And if they just have ear pain but you don't see any sign of infection, don't need to treat. Check for anemia. Now, the recommendation here is to look for palmar pallor. Do they have it? Is it severe or is it mild? Just some? And classify the anemia as severe if it's severe pallor, some pallor, no pallor. If they seem to be severely anemic, send them right to the hospital. If they're just somewhat anemic looking, give them iron. Give them mebendazole if the child is of the right age and hasn't had a dose in the last 6 months. And if they don't have any palmar edema, they probably don't have anemia. Now, we expand on this and recommend doing the finger stick estimation because you'll miss some kids. And sometimes when children are sick, they look a little pale. It's better to try to quantitate it to the best of your ability. If the child is receiving ready-to-use therapeutic food, you wouldn't have to give the anemia, the iron, because you have the micronutrients in the ready-to-use therapeutic food. RUTF is ready-to-use therapeutic food. Acute malnutrition. Now, that is depending on how you're screening for it, looking for edema in both feet, the weight for height or length, Z-score. If you're looking for moderate malnutrition, it's under 2, between 2 and 3, and -2 and -3. Severe acute malnutrition is between below -3. Now, if they have any complication, any other danger signs, if they have pneumonia, if they're on a therapeutic feeding program, are they able to eat it? Are they able to finish it? Are they not able to finish it? How are they doing with breastfeeding? All of those questions are very important to find out from the mother. And then you classify it according to your findings, bearing in mind that some people disagree with the MUAC less than 115, and I would have to go along with that under 12.5 is what we call the cutoff. Some people say that's too low, it should be 12.8 or higher. But too many acute malnourished children are missed if you rely on the MUAC. We should be doing the weight and the height and the weight and looking for wasting as weight for length or height. So complicated acute severe malnutrition, start the antibiotic, whichever is indicated, treat them kangaroo or in one way or another, keep their body weight up, skin to skin with mother, give them sugar, refer urgently to the hospital. Now, assuming that there's a hospital that will accept them, or that is capable of taking them in. Moderate, remember that most of the deaths are in the moderate group because there are so many more moderates than severe. So it's worse to be severe, but if you only look at the severe cases, you will miss the chance to save the lives of the majority of the children who die because of their malnutrition. So uncomplicated, severe acute malnutrition, give antibiotics, ready-to-use therapeutic food, counsel the mother, look for TB, and if they have moderate malnutrition, treat that with urgency. Counsel the mother, follow up, assess for TB when you can, and if they're above -2, they don't have acute malnutrition, and give them appropriate nutritional counseling. HIV infection. This is something that in many parts of the world, there's a very large number of children who are HIV infected and adults. It is very important to keep that in mind when you see a malnourished child or a sick child. Has the mother or the child had an HIV test? Classify it. HIV has become a chronic illness. With PEPFAR, it is not a death sentence. There's a lot of thousands of people, millions of people on long-term antiretroviral therapy, maintaining their health, living a normal life. The children are growing. It's not wiping out entire families like it was in the 80s. So this is a new day for HIV, but it's still a very serious problem. It's important to know and bring up the subject with mothers of sick children if she's had an HIV test, if the child's had an HIV test, and then follow the chart. This chart is to be used if they're not enrolled in HIV care. But many of the hospitals have thousands of patients. Small rural hospitals have thousands of patients in HIV clinic. So this chart would be to be. And then the staging for the pediatric HIV. We won't go into this in great detail. It's good to know that it's here. It's good to know it as a reference, but it's not the sort of a thing you're going to memorize going through time. Carried out the treatments. Carrying out the treatment, you want to give the appropriate oral antibiotic for pneumonia, and we've expanded these recommendations on our charts for not just children up to 5, but adolescent children, teenagers, adults, pregnant women. So follow the dosing. This just goes up to age 5. This is the recommendations for the inhaled salbutamol, which is albuterol, using a spacer that you can make, a homemade spacer that is being explained in this chart. The oral antibiotic, the anti-malarial, the artemether, lumefantrine tablets, the coartem, which is the artemether is artemisinin-based malaria treatment, which has really revolutionized treatment of malaria. So this is important for people to understand is here. We'll be seeing diseases. You see diseases that you're not used to seeing at home in the developed world if you're part of a brigade that is going up. This training is also directed at people who are very familiar with these diseases. We're connecting with people who are not familiar and people who are familiar. So we're building bridges from one perspective to the other, and of course including the community in this. So teach the mother to give oral drugs at home. Uh, the iron, this is very important when we talk about um, iron. That is a very toxic medicine, has to be kept out of reach of children because children can quickly overdose on iron. It's one of the biggest causes of overdose. So it's one reason we like to recommend vitamin and mineral powder because children are less likely to be intrigued by that. Teach the mother how to treat infections, serious ones and ordinary ones. The mouth ulcers with ginseng violet, the antiseptic. Again, I'd like to remind us not to be too casual about mouth ulcers in malnourished children. Vitamin A and mebendazole, oral bendazole, and the norms are there, but also we have that. And there are some things that are not given uh, in an ambulatory setting or in a brigade or done by a health worker, usually in the home. The clinics are handling things like IM gentamicin, diazepam, Valium to stop convulsions, um, medicine for severe malaria. That is not appropriate to be handled by in a brigade setting. Health worker making a home visit. Treating the child to prevent low blood sugar guidelines. And dehydration guidelines, very, very important. Oral rehydration, and there's been a shift in recent years away from the starting dose of sodium in the oral rehydration, which is like Pedialyte, was a little bit too high. The solute load kept the diarrhea, didn't allow the diarrhea to persist a bit longer. Mothers were concerned about it and didn't want sometimes to give it because they thought it was causing diarrhea. They cut back the sodium in the oral rehydration supplements. And also, if you don't happen to have the packets to make oral rehydration fluid, you can make it with sugar and salt, a liter with 6 teaspoons of sugar, half a teaspoon of salt or less. Err on the side of less when it comes to salt with the oral rehydration. But if you have no other choices, rehydrate with the home rehydration fluids. Don't count on being able to use IVs, but of course, if you have access and it's appropriate, there's times when that is like with severe dehydration. Ready to use therapeutic food. Now, this is something that is more and more used with severe malnutrition. The commercial products have been very important, very successful. Sometimes there aren't enough, and people have to make their own therapeutic food. You can there's a lot of different recipes. There's bars, there's cookies, there's pastes. Just be sure that if you're making a therapeutic food, that it has the same minerals and vitamins and fats, proteins, carbohydrates, as is recommended by the World Health Organization. So that information is available, and you can come up with recipes to fill that niche with locally sourced materials. And I meant to say too, notice the amount to give to the child based on their weight and also the duration, how long you should do it, when you are using ready-to-use therapeutic food for nutritional rehabilitation. This is treating the HIV infected child, the drugs, the side effects. this is important to know if you happen to have a child and you're seeing a side effect and you're wondering, could that be related to this or that antiretroviral that they're taking? And so here's a chart, a cheat sheet. How to manage the side effects, pain relief for the HIV infected child, and immunize the child, even if they're sick. Immunize them when you have access to them and you have the immunizations. Follow-up care, recommended time. Now here's another section on left-hand corner bottom. Measles with eye or mouth complications, gum or mouth ulcers, or a thrush. After 3 days, we were seeing them back. Look for red eyes and pus draining from the eyes. Look for mouth ulcers or white patches in the mouth. Smell the mouth. If you smell an anaerobic odor, that is an early warning sign of Noma, and that child needs to be treated as if they have Noma, the high-dose antibiotic, and be ready to get them to a higher level of care if that's necessary. Treatment for the eye infection, if pus is draining from the eye, ask the mother to tell you how she's been treating it. If the treatment's been good, but the child's not getting better, refer to the hospital. If the pus is gone but redness remains, continue the treatment. If no pus or redness, you can stop the treatment. For the mouth ulcers, if they're worse, or if there's a foul smell from the mouth, refer to the hospitals. Or start high-dose oral antibiotics, amoxicillin or Augmentin, and metronidazole. Start that high dose and refer to the hospital, but give them enough in case they don't go to the hospital. Fluids, both Noma and nutritional blindness have high mortality rates. And in the Sahel of Africa, there are regions that there is, for example, the beginning early mild Noma is at least 6% of the pediatric population experience that in their first 6 years. So that is a horrific incidence. Not all of those refer to cases that have severe sequela, but the sequela can be so severe that you don't want to take chances in that kind of a region. So treatment for thrush, that's there. Ear infections, feeding problems, anemia, and now follow-up care, uncomplicated severe acute malnutrition, moderate acute malnutrition, HIV exposed, confirmed, more guidelines to follow, feeding count. And this, if you're running into a malnourished child, having this cheat sheet, especially if you have a language barrier, the mother speaks one language, the interpreter is helping you to talk to the mother, having your little cheat sheet to run down to phrase your questions and then write the answers. This can be very helpful to give you guidance as to what to tell the mother. And feeding recommendations based on the age. Notice, for example, 6 to 9 months when the child is starting to wean. They're recommending to give thick porridge or well-mashed foods, including animal source proteins, vitamin A rich fruits and vegetables. Start by giving 2 to 3 tablespoons of food, gradually increase. So often, this is a critical time, and the child is being given a thin porridge, and often in a baby bottle, which is, of course, a deadly thing to do. Now, is HIV exposed child, if the mother is HIV positive and there's a concern about her passing the virus to the baby with breast milk, there's pros and cons of her continuing her antiretroviral and continuing to breastfeed the baby, and also the baby can have prophylaxis. However, if the recommendation is for her to feed a formula. Then she has to be helped, perhaps sometimes, to purchase the formula. She may not be able to afford that, and then the baby will become malnourished because she's not breastfeeding. So it's, even though you'd rather think that no mother with HIV would ever have to breastfeed her baby, in the real world it may still be necessary, and they just need to use the antiretroviral prophylaxis. Stopping breastfeeding, teach the mother how to use a cup, etc. The mother's health, when to come back, and guidelines. Now, we're going to the management of the sick young infant up to age 2 months. And since we've gone so carefully through a few of the charts, you kind of catch on to how they, and it's the same thing: assess, classify, and identify treatment methodically. That an incredible amount of mortality is occurring in the first month, and it hasn't been going down. There's been dramatic improvement in child mortality in children over 2 months, but the newborns, or the birth to 4 weeks or a month and up to 2 months, that early infancy is still a very, very risky time for children. So you're looking for bacterial infections, pneumonia, local bacterial infections, for example, the umbilical cellulitis. There's a lot of danger for these children. So look at the chart and see how you would classify those children. Jaundice, another big problem in the newborn. Diarrhea, HIV infection, feeding problem, low birth weight, prematurity, and or not on breast milk. Look at the immunization status. Don't give BCG to children with HIV. BCG is a live bacteria, attenuated. So if you think the child may have HIV, don't give them a live bacterial vaccine. But in places where TB is common, BCG does protect children from tuberculosis. So it's given to everybody except the young infants who are HIV positive or unknown. The schedule for treating the child, counseling the mother, and teaching the mother to give oral medicines at home. Immunize the children even when they're sick. Better not to miss the opportunity. Treat diarrhea, give extra fluids, continue. And these are the rules. And if you can't refer them, give them as much treatment in home, in the community as possible. And feeding recommendations. So you can see this is a incredible amount of information. Teach the mother how to keep the low birth weight infant warm at home. This is important, but what is interesting is so often people overdress the young children. They kind of go overboard, wrap them up so much even in the heat that they can overheated. So teaching them to use warmth when it's necessary, but also to allow the children to be comfortable. Care. And then a form for recording the management of the young children. And then Now, this information on skin problems applies to the older children. Skin problems. Now, the first one is the treatment or the rash that is often seen with HIV. The second picture is ringworm. The third one is scabies. Scabies, it can be very, very common in this population. The people who have inadequate access to water for bathing and doing clothing, they live in close quarters. Often it's warm. And children can suffer terribly from scabies and adults. It can cause, it is actually a child survival in risk factor because children can be so uncomfortable, they're irritable, they're anorexic, they're not sleeping well, mother's not sleeping well, and they can also become super infected, impetigo, they can get a strep infection, which can actually cause acute glomerulonephritis, like a post-strep kidney problem. So it really is not just a rash. It's not a minor problem. It's a serious, potentially serious problem in these children. This looks like measles. Oh, chickenpox. Okay, that's chickenpox. And shingles is the next one down, and then impetigo. And this looks like a fixed drug reaction. The next one is eczema. That's not a terribly easy to picture, but that is meant to look like eczema. And the next one down is a allergic reaction. Looks like a Stevens-Johnson syndrome. Okay, and that one is a 2 months form, and that's the ART initiation requirement and follow-up HIV. And when to return, important recommendations. Now starts the 5 charts that Mom has expanded. This one is the soft tissue infections of the mouth and face with a summary of the findings, questions asked, the observations, and also the Noma risk factors in the setting of, for example, the Sahel of Africa, when there are pockets in which 6% of the children under 6 have some degree of Noma, whether it is the full-blown horrific gangrene of the face or just a small lesion in their mouth. They have at least the beginning of the disease. So we have to be hyper alert in some parts of the world for Noma. This is a Noma staging. Stage 1 is a mucosal lesion, acute necrotizing ulcerative gingivitis, and number 2 is facial swelling, the cellulitis in the face that is starting from the inside of the mouth going out. These 2 stages are curable, completely reversible. However, if we go to stage 3, now we have the gangrenous plaque, and the child is going to lose some facial tissue. And number 4 is the scar tissue. Now, that is in the Noma classification, but there are other serious swellings of the face, for example, peritonsillar infection. Mumps is another one. Moving down, we've got stomatitis or gingivitis, and sometimes this can be malnutrition, even scurvy, vitamin C related, oral candiditis, strep throat, or tonsil infection, or just a virus. So that's the classification of Noma is the main reason we did this slide, amplified that. Nutritional blindness. On the left side is information about the risks and dangers, treatment, prevention, but then classification of the stages. Stage 1 is night blindness. Stage 2 is a dry eye, xerophthalmia. Stage 3 is Bateau spots. 4 is a soft corneal keratomalacia. 5 is a bulging eye, and 6 is a blind eye. It's curable all the way up to when the eye ruptures. So from stage 1 to 5, we should recognize it, start the vitamin A megadose, do all of the remedies, all the treatments. All of this is considered critical, and only when we get to the blind eye is it irreversible. Acute malnutrition, our chart is shown there, the weight for the age, background, and then what do you ask, what do you observe, the assessment of moderate and severe, normal. Now I want to make one comment here. There's a lot of talk about the ready-to-use therapeutic food. You can have homemade ready-to-use therapeutic food with eggs, or you can make a peanut butter bar. You can use super cookies, bars. There's many recipes available, but they have to fit the World Health classification of what they want to see in a ready-to-use therapeutic food, the amount of calories, fat, protein, carbohydrate, and also they should be high in macronutrients and as well as micronutrients. Macronutrients, especially to prevent the refeeding syndrome, the magnesium, the phosphate, the potassium, calcium, all and low sodium, all really, really important. So that's important for the acute malnutrition. But when there's only moderate wasting or normal, instead of just 1 scoop of micronutrient powder of our formula, we've increased the recommendation to 2 for all the children living in communities that have a high risk of chronic malnutrition. The assumption is that the community is our patient, and if children are living in those circumstances, the 2 scoops throughout their years from 2 to 12, and then the higher dose in their adolescence when they need it for the adolescent growth spurt is what we're recommending now. So everyone over 12 should be given the adult dose, which we used to just give to the childbearing women, but it makes good sense if the whole community is affected by the malnutrition to give it to everyone that is possible to make it available for. Chronic malnutrition, the same story with the ready-to-use therapeutic food, same information, and also the recommendation for the micronutrient powder, 2 scoops for every child from 12 months to 12 years. 1 scoop if you're under 12 months, 6 to 12. The anemia, severe, mild, moderate, and the micronutrients in the Norlin micro, or the Micromix now is the new brand. The 2 scoops for everyone, 3 if you're severely anemic, and you don't need to use iron liquid or pills if you've got access to the micronutrient powder. And we don't recommend just looking for palma or anemia. We do recommend trying to quantitate it because it is difficult to tell by looking at a child if they're anemic. If you have the ability to quantitate it, at least quantitative estimate, not a true quantitation, but an estimate, that gives you a little more information to base your assessment on. And we, like I said before, the children who are normal, they don't appear to be anemic, they should still get the 2 mini scoops of the micronutrient powder daily. Thank you.